Hello, good morning, afternoon, and good evening to all speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to the ACNS webinars. The speaker for first session today is our honorable guest from India, Prof. Sukumar. Prof. Sura is a senior consultant and chief of spine surgery, Center for Full Endoscopic and Minimally Invasive Spine Surgery at the Asian Spine Hospital, Hyderabad, India. He also has been specially trained in percutaneous endoscopic lumbar and cervical disc surgeries, both in India and abroad, which is in a Buridul Spine Center in Seoul, South Korea, for lumbar and cervical disc prolapse. He is one of the most sought-after faculty for various workshops and conferences involving endoscopic spine in India and abroad. He has published several scientific papers in national and international journals. We are extremely honored to have him today at our webinar, and today he will be talking about his favorite topic, which is endoscopic spine surgery. The speaker for the second session today is Prof. Amit Thapa, and his lecture is on endoscopic intracranial hematoma evacuation, challenges and solutions. Prof. Thapa is the head of the department Neurological Surgery at the Kathmandu Medical College Teaching Hospital, Kathmandu. He is the Vice President of the Nepali Society of Neurosurgeons and Nepal Epilepsy Society. He is the chairperson and founding treasurer of the Neurospine chapter of NISON. He is a note author with several publications in various peer-reviewed journals and was also the past editor-in-chief of the Nepal Journal of Neuroscience. We are extremely grateful to have him for accepting our invitation for the second session today. The chair of the first session is our honorable faculty from India, Prof. Ajif Nair. Prof. Nair is a senior consultant neurosurgeon at KIMS Health, Trivandrum, Kerala, India. He is a leading endoscopic spine surgeon in Kerala who also specializes in endoscopic brain surgeries of the skull base. We are extremely grateful to him for accepting our invitation to chair this session today. On behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to welcome both the speakers and chairs and the audiences to this online platform of ACNS webinars. Very warm welcome to our colleagues in China, and we are extremely thankful to Prof. Subin for broadcasting the webinar on the WeChat channel. Dr. Liu Bun Seng from Malaysia is my co-host for today. With that, we would like to hand over to Prof. Ajif Nair.
Thank you, Sam, for your nice words. Actually, when I started my career long back, there's a saying that to kill a flea, you have to smash hole of the window pane, because the surgery for lumbar spine and even cervical spine was so mutilating, and even the side effect collateral damage that we make is more painful than the pain of lumbar disc herniations. But now it was just gone to a stage of laser bombing. That is, a precise area will be addressed and the collateral damage is reduced to minimum. And we are extremely lucky to have one of the pioneers of this field, Dr. Sukumar Sura, who popularized this technique in different parts of India. So we are honored to have him here in this platform, and let him please start with your topic.
Yeah, thank you, Sam, and thank you, Professor Nair. Good evening, everyone. Good morning, all over the world. So thanks ACNS and the committee for giving us the opportunity to just have a bird's eye view what full endoscopic spine surgery can be done today in lumbar, thoracic, and cervical spine, which might be the game changer in future. So the end of my talk, I think I might convince you people that maybe this is the future, and it might change what the perspective of spine surgery, what we are doing today. So thanks to all these gentlemen, where these are the one who dedicated their life to spine endoscopy, starting from Professor Kembin to Dr. Gore, who spread the endoscopy all over the world, persisted with the failures, and whatever we are doing or whatever we are achieved today is all the hard work all these people have done. And I'm fortunate that I have learned so many techniques from most of these people. So any spine surgery, traditional spine surgery, for the sake of removing that 5 to 6 mm of pathology around the nerves, we have to do a lot of opening and resection of the area leading to collateral damage. For that, there have been lot been debated all these years, and the ultimate aim of any spine surgery is to decompress the neural structures, either it being a disc, ligament, or osteophyte or hypertrophic facet. The idea is to decompress the neural elements. So how are we doing that? Moving from the traditional surgery, open surgery, we moved to microscopic surgery. Then came the tube, and then tubular endoscopic spine surgery, tubular assisted endoscopic surgery, microendoscopic surgery. There were a lot of options we had or we were doing, but still every technique has some problem. We are not happy always, and still patient is not fully happy at the end of the surgery. So there are some problems. What are these problems? The limitations are, there is some tissue trauma, definitely. There is a bloody field because we are using a dry surgery. It is not a wet surgery, so you will still have a bloody field. And most of the microscopes or the endoscope that tubes use are 0 degree. Magnification is limited to some extent, and the reach going to looking to the opposite side, that the opposite recess, is always a challenge. We have to do most of the time with the feel, and probably we have done adequate decompression because the reach is always a problem. And mobility and maneuverability, because we are working with the fixed systems where either with a tube or microscope, every time we have to move or to look into the opposite spaces or narrow spaces, again we have to detach it or move the system every time. So the mobility and maneuverability is always challenging. So how can we overcome? Yes, definitely we can overcome, or we have overcome with this endoscopy to larger extent. Definitely, most of the things can be curtailed with whatever problems we were facing with the conventional or advanced approaches today with endoscopes. These are the what do you mean by full endoscopic spine surgery? It's a monoportal wet endoscopy, and it is dynamic. The word dynamic is because you are always moving. It's zooming in, zooming out. You can move it to cranial, caudal, medial, lateral, and it is done under saline irrigation. This helps a lot, and it is monoportal. Everything is done through one port. The working channel, light source, irrigation, everything is a camera is through one port. So how does it help? Because of single irrigation, because of saline irrigation, you have excellent magnification and visibility. The structures are so beautifully seen, and because of the angled scope, the 25 degree, 15 degree or 30 degree scopes, we can see the opposite, the over the top and the opposite lateral recess very easily. That's the advantage of this angled scopes. And with the local and epidural also, the spine surgeries can be done with endoscopy. Actually, it has added what is the extra thing to the spine surgery where patient who is not fit for GA or is having comorbidities or more, then we can even do it in local or epidural. And of all the techniques which we see today or we are practicing today, endoscopy is the least invasive approach. The monoportal wet irrigation endoscopy is the least invasive approach. What do we use here? We use a single tube which has a working channel varying from 4 mm to 6.5 mm. There are irrigation ports, either 1 or 2 irrigation ports, and a camera, the lens, rod lens rigid rod lens will be there, which will be attached to the camera system. And the drills which are especially made, these are low speed, high torque drills so that we can drill precisely. And biggest thing is the RF. So the radio frequency, high radio frequency probes and the generators are the key for operating endoscopic spine surgery. These are the simple armamentarium or extra things, tools we use for a full endoscopic spine surgery. And the basic concepts are in endoscopic spine surgery, there are two basic techniques. One is transforaminal technique and one is interlaminar technique. Transforaminal technique is a posterolateral technique where we go through the safe triangle of Kembin and enter the area and address the pathology. In interlaminar technique, it's the same as we every day in and out, we go there through the interlaminar window and operate around the pathology. So that's the interlaminar technique. These are the two main techniques which we have to, every surgeon has to know to master this technique. What are the differences? I just enumerate the differences. What are the differences? You can just see when you see the differences. The scar definitely today is a big issue. I fully agree with the scar. Definitely, when you say the scar, when you say 1 inch scar with a 7 mm scar is definitely different. So definitely we can reduce the scar. Mobility and the reach, definitely yes. Upper pedicle to lower pedicle work can be done, and the medial lateral work to the opposite lateral recess, it can be easily done with this endoscopy because it is dynamic and mobile. As I said, mobility, you can see here with a single entry, you can reach till the inferior pedicle to superior pedicle, and you can work easily in this way. You can see here how I am rotating the scope, seeing the opposite side. You can see the opposite side. I am with such a big good clarity. I am seeing the opposite recess. And the third video is a mobility. You can see the mobility, mediolateral and craniocaudal mobility. Such is the mobility you can attain with a single small entry. This imaging, you can see the opposite side. My sheath is standing in the or just staying in the midline. Scope is going beyond the midline. In a tube surgery, the scope or the sheath cannot go beyond midline, where the opposite recess is not visualized better. Here, because the scope is small, you can take the scope as near as possible. It's like people always say, taking your eyes near the pathology. So you are directly taking the scope near to the pathology. And drilling, you can see here, I'm doing an extra flavor drilling of the opposite facetolaminar junction. So you can see how beautifully you can do it. Just I am drilling the opposite laminofascial area without opening the yellow ligament. It's called extra flavor drilling. And still you can see what you are doing. That's the beauty of endoscopy. You can still see what you are drilling. Clarity. So you see here the vasa nervosum on the nervous tissue is so clearly seen. This is the beauty of endoscopy. Because of the saline irrigation and magnification, you can see the minute pathology very clearly. Even if you injure a dura, you will easily identify, you can easily identify whether rootlets are coming out, the arachnoid is intact. Everything can be seen very nicely. And the angle, as I was talking about, when we look at the microscope and 0-degree endoscope, the angle is limited. Even if you use a 0-degree endoscope, it's hardly less than 180-degree vision. But when you use an angled scope, the vision increases so much, it is definitely more than 180-degree. So as a result of which, you can see all around very easily. Any obese patient is very easy by endoscopy. You need not worry about the obesity here, because whatever the obese lady or person, gentleman, we can directly go into the area of interest and start working. So most of the pathologies, either lumbar, cervical, and thoracic, can be dealt today, and there are very wide indications. So most of the indications what we operate today for spine surgery can be operated today with endoscopy. Being endoscopic discectomy, foraminal stenosis, lateral recess stenosis, or central canal stenosis, or any foraminal extraforaminal disc, multi-level disc, in especially in young individuals, dorsolumbar or upper lumbar disc, it's very easy through endoscopy. Dorsal discs especially are very challenging in open surgery, which can be easily dealt with endoscopy. Cervical disc, a set of patients who has a lateral disc or a foraminal disc, can be dealt with endoscopy with the posterior laminoforaminotomy. And there are chronic annular ulcers, that is high intensity zones which doesn't heal. We can easily deal with endoscopy debriding that area. Adjacent disc disease, discitis, and fusions today we commonly do with endoscopy. As I said, there are two main varieties of approaches. One is transforaminal and interlaminar. Today, I'll just go through the transforaminal approach first. What all transforaminal approach has changed over the past decade. Initially, it was only for the disc pathology. Today, we almost do for other techniques also, the up-migrated, low-migrated stenosis, foraminal, extraforaminal, or even dorsal pathology also. So transforaminal, when we say, we can see here, it's a case of L4, L5 lateral recess stenosis with the lateral disc. So how you go about it? Patient lying supine and you laying prone, and either in local, general, or epidural analgesia, you place a needle in the triangle of Kamin and enter the disc there, and put a dilator over the needle and enter the space. So it looks like this. Once you enter this space, the disc, whichever is pathological, then you shrink the disc and just withdraw the cannula a bit, and again just give a nick on the annular fibers which are diseased and thinned out here. And you can see I'm just trying to hook out the disc material. Don't be happy if you have removed a fragment. You just removed a fragment, still there is a fragment there. Just coagulate it, string the adjacent disc which is floating. You can see there is a further disc material there. Try to remove the disc. There is one more fragment. Can remove that. One more fragment is there. So till you see the thecal sac or the root, you should not be happy. There's still some fragment. Now you can see a thecal sac is seen there. What I am doing is I am trying to just debride that area, expose the root, the blood vessels which are just adjacent to the root. Because this patient has a lateral recess stenosis, we need to decompress the lateral recess as well. Now you can see the root is completely free laterally, ventrally, and posteriorly. So this is the post-op MRI, immediate post-op. You can see nicely the entire recess is decompressed. There is no violation of any muscle here, and no facet has been touched here. So as a result of which, it is a least invasive approach where you have not violated any structure here. Inferior migrated disc, definitely yes, you can do with the transforaminal approach. Just land there and remove the fragment. You can see here in this case, patient had 4-level laminectomy in the past 10 years back. Now, 10 years later, this patient has come with a recurrent disc in L4, L5, and if you want to again go for a redo open surgery, definitely you end up in fixation. So this patient, we did a transforaminal surgery, removing the fragment entirely, and L1, L2 surgery. You can see here the post-op, entire fragment is removed. You can see a previous scar which is so lengthy incision was given for the 4-level laminectomy before. Foraminal, extraforaminal, you can see it's a L4, L5 left foraminal, extraforaminal disc here. These discs are very painful or very symptomatic, and they are very happy once you remove this small fragment. If you want to do a open surgery or reduced surgery, you have to go with a Wiltsay's approach here and address the fragment. Endoscopy is very easy. Just land in the foramen, and this is the way we do it. Just land in the foramen. You can see the cranial caudal orientation because it's being a left side. Cranial is 9 o'clock, and once I've landed there, the exiting route would be at the 9 o'clock. So I'm just exposing the disc fragment which has ruptured out. That's the disc fragment which has ruptured. I'm just removing the extruded fragment there below the exiting route. That's the fragment. One more. Once you remove the fragments, you see the bleeding from the epidural space. That's the epidural space. But there's still some fragments which are inside the annulus. So there are intra-annular fragments. You can see between the annular fibers, you can see the fragments. Remove the fragments, intra-annular. I cut a bit of annulus here and remove the intra-annular fibers. So there's so much of intra-annular, intradiscal fibers. I am removing that intradiscal fibers, the fragment now. The one more fragment. This is epidurally located fragment. I am removing that. That's like now you can see the root start falling on. All this time root was lifted up. Now root has been seen nicely. That's the root. So now we have removed all the loose fragment. That's the exiting root and the traversing root junction. So I just trim that area and confirm there are no loose fragments. So that's the exiting root at 9 o'clock to 12 o'clock. Then that's the junction of exiting and traversing area. Foraminal stenosis, some isolated patients, especially the elderly patients, you have a foraminal stenosis with just radicular symptoms with no back pain. Such patients, we can directly do a foraminoplasty and give them benefit. Upper lumbar disc, definitely, this is a young lady, postpartum, had a severe low backache with a L1, L2 disc extrusion. So transforaminally, we approached, entire disc was removed. There was a hard hump which was removed, and you can see the thecal sac well pulsating. And the astonishing thing is, patient was operated in November 18, and you see what happens after immediate post-op and current post-op. That's December 2020. There is complete resolution of the fragment is gone, and it's almost looking like a normal disc there. Annular ulcer or high intensity zone or chronic annular tears, where you see so many patients like this, where they are suffering with chronic low back pain with multiple pain management sessions, still they don't improve sometimes. Such patients, we can go endoscopically and debride the area. These patients, they bleed a lot because there's a lot of neovascularization and granulation. This patient bleed a lot. This patient was a patient where there was tough bleeding. Adjacent disc disease, again, adjacent disc disease, whenever you do a fusion, some patients, unfortunate patients, they develop adjacent disc disease. For them, we definitely, if they are elderly, we can give a choice of decompression transforaminally, just decompress the area, and if at all any disc removal has to be done, you can do a discectomy. Again, any discitis patient, such patients who have a severe discitis, either de novo or post iatrogenic post procedure, definitely these things can be dealt easily with transforaminal approach, where we can put a needle, try to remove the contents. You can see here there's some content coming. I will try to aspirate the purulent material coming inside. And the appropriate antibiotics can be given after culture sensitivity. And later you can degrade it. So fusion today has changed the perspective of endoscopy because most of the patients, or 40% of spine surgeries, are fusions. So whenever you want to do a single level or two level fusions, definitely it can be done either by transcambian approach, that is posterolateral approach, or through the interlaminar approach. First, we'll see the transcambian approach of fusion here. You can see that this is a case of stenosis. In such patient, what I do is first go interlaminar, decompress the interlaminar space, then go transforaminal and insert the cage. So definitely they fare very well. And best part is you are doing a visualized end plate preparation and packing the graft anteriorly and putting as oblique cage as possible. This is a case where patient had been operated once already and there's a degenerative disc disease has come with recurrence. I went interlaminar, removed the disc fragment, then went transforaminally and inserted the cage. This patient again had twice microdiscectomy done. There was a recurrent disc with a severe radicular symptoms. So this patient we operated transforaminal, entire removal of the disc fragment and insertion of a 12 mm cage into 30 mm cage we inserted. This is with the graft packed anteriorly and to the opposite side. This case, severe fascic disease, 2 levels with mobility. We did a 2-level endoscopy with transforaminal approach and did a nice reduction. And patient was asymptomatic post-op. This is a cage you can see with the graft inside. So coming to interlaminar approach, whenever you say transforaminal or interlaminar, both are complementary. What does interlaminar approach do? Because of the mobility, it gives more versatility to our armamentarium. The stenosis, especially in elderly, can be dealt with interlaminar approach better than transforaminal surgery. Or patients who have a chronic disease are dealt better with the interlaminar approach. Again, it is same concept, except the size of the instruments and the scope is small. And how it is done, I just go through a small demonstrative video. It's alpha S1. Patient is prone with a GA and you are gone with a small tube. Once you go there, you see a small muscle fibers. And once you remove the muscle fibers, you see a yellow ligament to do a luminotomy and retract the root and just rotate the sheath and do a disc removal. So this is very simple. If you are dealing with the L5S1 pathology, 10 to 15 minutes, your job is done without any damage to any muscle or bone tissue. Inferior migrated disc, for example, such patients where there is a huge migration of disc to almost starting from L4-5 coming to the L5S1 and going beyond. So these patients can be dealt easily. You can see I have drilled the upper lamina and lower lamina here and removed the entire fragment. This is a post decompression. That's being the right side here, 3 o'clock in cranial. That's the disc space. That's the PLL. And the disc was here, lying here, and entire fragment has been removed. The entire fragment has been removed from the axilla, and the patient goes home without any much major trauma to the muscles. This was the patient. This is a post-op immediately where she was walking straight. Lumbar canal stenosis is this I think is a game changer in endoscopic spine surgery because so many elderly patients who have only neurogenic claudication. Today we are offering them fusion. So we can avoid fusion when there is no back pain. Patients are okay and patient is 70 years plus just do a decompression, endoscopic stenosis decompression, going over the top and decompressing the opposite recess as well. They fare very well and are very happy patients. These are the decompression. You can see we have done a decompression here. That's the opposite side, the opposite recess. It's opposite recess. You can see the opposite recess. The clarity here because of the saline irrigation and the mobility of the scope, you can go to the opposite pieces very easily, maneuver it very easily. You can see the sheet is floating and my scope is moving. That's the midline. That's the midline. That's the what you say, the upper lamina spinous junction there. That's the thecal sac. Then coming to the ipsilateral side, the entire ipsilateral, contralateral, and the thecal sac is being well decompressed. This is the immediate post-op. You can see the post-op completely, it has been decompressed. Facet cysts, there are patients who are suffering from severe radiculopathy without any back pain, especially elderly patients where there is a facet cyst. People do pain management, they do a lot of needling, CT-guided needle aspirations, but they're all temporary procedures. There is no need for PLIF or fusion in this patient. Just do a decompression and they do very well. We did just a decompression. We have our own series of around 12 patients now where we run a facet cyst removal and the lateral recess decompression. So this is a decompression we have done, and this is a post-op. Patient is still under follow-up now, almost 4 years post surgery. Is still under follow-up. Is a 75-year-old Air Force retired pilot. So he is still under follow-up. He is happy, no radicular pain. Dorsal spine again you can do either transforaminal or interlaminar. So transforaminal, especially the upper dorsal discs. This was a D9, D10 disc with severe radiculopathy. We went 8 centimeter from the midline, go there. The dorsal spine, the main challenge is the rib head which comes in our way. Sometimes we have to drill the rib head. Above D8, there is a rib head in the disc space. You can see in the X-ray, D8, D9, you have a rib head, D9, D10, there is no rib head coming in our way. So D8 and above, always we might have to drill the rib head also and enter the disc space. So this is a disc and you can see the thecal sac is well pulsating and the disc has been removed and the space has been well decompressed. Patient is happy post-op and you have not done any fixation for him. He is very happy. D5, D6, this is my uppermost disc. So patient came with paraparesis. He didn't wanted any open surgery. So we went ahead with D5, D6 surgery, which is symptomatic for now, and operated him and went almost 7 centimeters from midline and removed the entire fragment. And patient, you can see the post-op, the entire disc is removed, and it's called a trumpet osteotomy where we do a drilling which opens up the posteriorly and any osteophytes we can easily remove in this way. This unfortunate patient had disc, but someone did a decompressive laminectomy because patient went to the doctor with the paraparesis, but wrong level was done, and again there was some more extension of the laminectomy. There were almost 10 level laminectomy was done in this patient before this patient come to us. Still having paraparesis. So we did a transforaminal approach, went there, you can see the scar, went there just para sagittal or para midline and went into and drill the bone, drill the facet and completely remove the osteophyte. You can see the pre-op and post-op. The pre-op on the left side and the post-op on the right side, almost entire osteophyte is removed. Patient paraparesis is still there, but she is improving. Interlaminar dorsal spine, definitely cases like this, where you have a ossified yellow ligament. Such isolated patients can be dealt with endoscopy, go from posterior, then drill it, and you can see this is a thecal sac decompressed nicely. The thecal sac decompressed nicely, that's a thecal sac bilaterally, and this is post-op. Entire calcified or ossified yellow ligament is removed, and you have avoided a big fusion for surgery for the patient. So one more patient, ossified yellow ligament with facet capsule calcification. Such patient also, there is no need for open surgery where we end up in fusion in such patients. This patient was done in interlaminar approach where entire facet was drilled, and you can see that that's the disc. So this is superior, inferior. It's a midline. That one beyond the midline here, it's opposite side, opposite recess, well decompressed. So bilateral decompression was done in this patient, and this is post-op. So entire complete decompression, removal of the entire yellow ligament or ossified complex, and you can see the beauty of endoscopy here. Cervical, that's called postero-laminoformnotomy, where you go posteriorly. Such cases where there is isolated extraforaminal, foraminal or lateral disc. Such patients fare very well without ACDF. You just go there because patient has only radiculopathy, and you go there. This is a right-sided patient, 3 o'clock, being cranial. You can see the disc is in the axilla. Fragment coming out. So that's a big fragment, axillary fragment which is coming out, and that's the thecal sac and the root decompressed very well there. And you do a small window. You can, you think you've done a big bony defect there. It's a very small laminoformnotomy where which does not cause any facet instability. Then the endofusion, as I said, there are two approaches. One is the transforaminal approach, that is transcambian approach. The second approach is the posterior approach. That's entire facet is removed en bloc. What we do, and you can insert a case. So it's the same as open surgery where we remove the entire bone. So this is the way we go. First, we go posteriorly. This is the concept. Remove the entire bone from pedicle to pedicle, medial to lateral. Remove the entire bone. This article taken from Chinese article, where this is a concept. You remove the descending facet and a part of ascending facet, and entire the window is cleared from pedicle to pedicle, where you can decompress the exiting root, traversing root, and insert the cage between the two nerves very easily, as big cage as possible. And this is the graft I remove. 5 to 8 cc of the graft can be easily removed, which most of the time, even in open surgery, we pack the graft like this. And this is what we can achieve. You can see the cranial and caudal. So at 3 o'clock to 6 o'clock, this is the exiting root, that's the exiting root, that's the traversing root, and in between is the disc. That's the central canal and the opposite recess. So you can decompress the opposite recess, ipsilateral recess, and the central canal, and at the same time insert the cage here in the disc space. Because of this vision, chance of root injury very. Once you do this decompression, then enter the disc space. You can see that in the left image, this anterior fibers, anterior fibers, annular fibers are decompressed. 2/3 of the end plate prepared. The lower end plate is the upper end plate. Gone deeper. It's anterior annulus. Now, anterior annulus, then once you do this, you pack the graft nicely anteriorly, as anterior as possible. Then I use the screw port as my cage entry. This is what we have practiced so far. We have done almost more than 50 cases now. Just insert the cage, under visualized insertion. So you are seeing through the scope and you insert the cage through the screw port. So as a result of which you are not damaging. Just go through the cases here. You can see this is a severe stenosis patient with a grade 1 to grade 2 listhesis. We have gone here with augmented screws and decompressed the entire canal and put a cage here. So, and it has well reduced, and you can see the graph placed nicely there. The second case, again, the severe stenosis with a grade 1 listhesis, nicely reduced and cage placed as anterior as possible. This is again one more case. It's how we take a facet graft and pack the graft and put the cage as anteriorly as possible. Expandable cages can also be used where the tubular cages or even the MIS cages can be used with the lordosis, and grade 2 or grade 3 listhesis can also be easily done. This is what the message. Even in such difficult cases, go there, prepare the end plate nicely, put the screws, reduce the system, and jack up the system as bigger case as possible, and you can attain good lordosis in such cases. Two-level endoffusion can be easily done without any hitch if pathology warrants two-level fixation. Definitely limitations. As I end my talk, the limitations are the learning curve. Monoportal definitely has some learning curve, and the cost of the initial setup is high when compared to the open surgery or the MIS surgery. Recurring cost today is high, but with the advent of multiple companies and the local companies making more and more cheaper instruments, the cost in future will become as equal to as open surgery. The training part is the one which is lacking now. We need to have a proper training, method. I took this slide from East Pioneer Academy, where this is how fellowship or a training process should go. First is a person should visit and attend some different workshops and cadaveric workshops. Then he goes to a supervised surgeries. Then next he goes to multiple meetings and joins a fellowship with a good master or a expert. From there, he becomes a faculty and starts training further. So this is how the training should be, so that people should not learn bad things and do a lot of mistakes and say this technique is bad. Future, definitely, yes, there is a very bright future for endoscopy with the advent of flexible endoscope, and navigation in spine endoscopy is the future. And endoscopic assisted fusion, as you saw, both transcranial and interlaminar, this is going to be the future. So this will change the scenario in future, and the trauma is reduced further, and the post-op paresthesias is going to get mitigated in future. Thank you. Namaste for the opportunity and the time. Thank you. Over to
Thank
Professor.
you. Thank you, Dr. Sukumar, for this excellent overview of what can be done with endoscope and what you have done. And you have gone through from simple extraforaminal, transforaminal to endoffusion, and what will be the, you enlightened us with what will be the future of this endoscopic spine surgery. So when we started, there are a lot of apprehensions. That is the transforaminal, because somebody has divided into transforaminal, extraforaminal, intraforaminal. I don't know whether there is any clear-cut differences between these techniques. So regarding this, my question is, what is your perception regarding somebody starting endoscopic surgery, whether he start with the transforaminal or whether he start with an interlaminar, and how often you what is your percentage of your transforaminal and interlaminar, And do you find any real difference between extraforaminal, intraforaminal, and transforaminal? And do you think this extraforaminal is more safer than you directly go intraforaminal? We just compare. And one thing more about the many of the people advocate surgery under local anesthesia. That for many of us, if in a civilized society, a patient, it is very difficult to convince a patient for a under local anesthesia. What is your perspective regarding these aspects?
Yeah. So to your first question, whether a beginner should learn transforaminal or interlaminar, definitely, as I said, he should learn both. Both are complementary. One will not replace the other. You cannot do every spine surgery through transforaminal approach alone or interlaminar approach alone. So both are complementary. That's why every person should learn both techniques. With my experience, if he is going for a L5S1 disc, go for interlaminar. If you are going for L4, L5 or above, to start transforaminal. If you think transforaminal is difficult, then you go interlaminar. Because transforaminal is least invasive, better go transforaminal. So as a beginner, you need to learn both, because if you want to do a L5S1 disc and you force yourself going transforaminal approach, because of the high riding iliac crest, you might injure sometime the exiting nerve. So you might injure. So that's why, or you might do an inferior surgery. So interlaminar approach is very easy because of the wide interlaminar window. Just go interlaminar approach and finish your job in 10-15 minutes. So that's why as a beginner, when you want to learn, always try to learn both. So second option, the second question, coming to transforaminal approach, which is better, whether inside out or outside in, it's again depends upon with whom you are getting trained. If a mentor is very good in outside in approach, then go for outside in approach first. But your mentor is very good in inside out approach, go for inside out approach. But either way, the work should be done. You should not miss the pathology and you should decompress the nerve at the end of your surgery. The third thing, whether it can be done under local anesthesia. Yes, transforaminal can be done under local anesthesia, but as in my own hands, initially I started with local anesthesia for my first 200 or 300 cases we did under local anesthesia. But later I felt that the journey of surgery of the patient is very painful or very scary. So to the surgeon and to the patient both, because when you are doing under local, sometimes because of the neurotization of the tissues around, even you touch a facet joint, patient will say, there is a radicular pain in my leg. And you keep on giving local there and you numb the area, and ultimately you might even injure the nerve and you don't know what you have done at the end of it. So that's why I started doing epidural analgesia, where patient has less pain. Still, he can identify some pain whenever we are touching the nerve, and we can still identify that whether there is a pain. So I found transforaminal surgeries under epidural analgesia better. But nowadays, after now we have done around 2,500 cases, I find even transforaminal today I do under GA. But I suggest the beginners not to do under GA as a first choice. Start with local or epidural, not GA, because you don't know what you are doing and you might injure the nerves. Coming to what you say, so yeah, I think I have almost answered your questions.
Yes.
Definitely, the bottom line, they should learn both techniques.
Okay, it's a very good answer. I just know this CM, the true lateral, true AP, everything is very important in navigating the scope when they are doing a endoscopic disc surgery, because initially it is very important, but as you gain more experience with a single stroke, you can reach the ligament flavum, you can reach the foraminal region. But is it necessary for somebody who is dedicated in using C-arm is needed in the initial phase, or is it very essential, this getting a good C-arm shots in the initial phase?
Yeah. So coming to the C-arm and radiation, transforaminal surgery has a lot of radiation because as a beginner, trying to place a needle going to the transforaminal area and appropriate target, you might end up in taking 100 or 150 shots. And after that, some more shots. So definitely when you compare transforaminal surgery and interlaminar surgery only takes 5 to 10 shots maximum. But transforaminal surgery average, a beginner might be taking around 100 shots, which is too high. Second thing, yes, if your C-arm technician is very good and you are parallel, when you are in lateral, your end plates are parallel, then definitely the number of shots and the angle you go inside and injuring the end plates and the nerves is very less if you are, parallel. As I said, radiation nowadays, there are various navigation tools coming up. In coming 2 years, we will have all the navigation tools, which existing navigation systems, you will have a transforaminal endoscopy navigation tools also, where this radiation becomes much lesser, and the beginner can easily reach the foramen without much radiation.
Yes, thank you for excellent answer. One more question. After that, I will give to the podium. How many percentage of cases you see all the foraminal stenosis, extraforaminal disc, then the centrolateral disc, and in your experience, if all the what is the percentage of cases that can be done with the interlaminar approach that cannot be done with the transforaminal, and vice versa?
Yeah. So today in my practice, I do 70% of my cases interlaminar. The transforaminal has become much limited, limited indications to foraminal or extraforaminal disc, or in patients who are disc height is normal and there is no chronic elements like stenosis. I prefer transforaminal. Upper lumbar disc, transforaminal. Dorsal disc, transforaminal. This is my indications today. Interlaminar is more versatile. Most of our patients, especially the subcontinent or Indian patients, have a chronic etiology. Most of the patients have some chronic elements in the form of ligament hypertrophy, facetal hypertrophy, or collagenization of the disco-osteophyte complex, as a result of which we need to address all these things at one go. Interlaminar becomes much easy. Second thing, interlaminar is much versatile, where patient is under GA and it's your routine path which you are trained in open surgery. Doing and reaching there is much easier. So today I practice more interlaminar because of these reasons. So my practice, if we want to do a foraminal extraforaminal disc, still I can do interlaminar approach. It's called contralateral, over the top, going to the opposite side, entering the foramen, removing the disc fragment. Still we can do it. But a foraminal extraforaminal fragment, transforaminal approach is very simple and easy. So today, if you learn both techniques, you can do most of the cases.
So let me ask you a question, because you said you are mostly, because initially you start with the most of the extraforaminal, transforaminal, then now your 70% of work is interlaminar. So you are indirectly saying that almost 100% of cases that can be done through the interlaminar route.
Once you become experienced, yes.
Yes. So my question: everyone is starting with extraforaminal, because that is, it has some inherent problem, because you can injure the root, and I have seen patients injured. The ganglionic injury is very pathetic, because patient come with a severe pain. And even the patient remember the pain during the surgery, because even if you give a lot of local anesthetic, they have a severe pain.
Yes.
Still, you are saying that you have to start with the extraforaminal. Initially, you have to start with why you are saying like that? You have to start with the transforaminal technique, then go for interlaminar.
No, I am not telling like that. So what I am trying to tell is learn both. Learn both. Only if you have
So
a
for
problem.
that I mean initial phase, what approach a beginner should start with?
Better you go for interlaminar approach. So for the safety.
Yes, yes.
Yeah.
Okay, good. There is one question in the inbox, that is, what is complication of the transforaminal? What is the what are the complications of transforaminal technique?
Yeah, normally the common injury of a transforaminal surgery is the stretch or injury to the exiting nerve, where it also has a ganglion, where your foramen is narrow or your entry is oblique, or you are stretching too much, trying to reach the pathology. Most of the time, patient complains of post-op paresthesias or burning paresthesias or numbness in that root area. This is a commonest complaint person notices. Second complication, normally transforaminal surgery is underperforming the surgery. You removed a fragment which is soft. You have left the hump which is still there. It's a chronic hump which has not reduced. When you go from below, you think you have removed all the pathology, but still you have left the hump. So this is the what you say, underperforming the surgery, the second commonest thing we do. And third is the root injury in transforaminal. If you are not following the strict principles, you might end up in damaging the root, which is very devastating. And fourth is the infection, which is common with any other surgery. A patient can develop discitis. These are the four common complications I see in transforaminal surgery.
Okay, anybody from the yes, Dr. Amit Thapa, you can ask it.
Yeah, thank you. Professor Ajit and Professor Sukumar. I was listening to both of you, very lucid talk and very great discussion about it. Well, personally, my experience had been like a transformation from a microscopic surgeon to a uniportal, and now I'm doing a UB techniques or unilateral biportal endoscopy. And I even see in one of the slides, Professor Sukumar putting the cage and then using the screw port as another for the cage placement. So it's basically a UBE, what you are doing, a triangulation method. What benefit I have actually realized by taking UBE is that for the places like us where we cannot afford to have very customized instruments for every segment, which is demanded of uniportal, UBE we can actually use the same system, the same scope and the same instruments for every segment, and we don't have to go for other specific instrumentations for that. What is your idea about UBE as compared to uniportal?
Yeah, they see. Bottom line is whether the time has come to debate whether endoscopy versus tube surgery. Now it is gone. Now it is uniportal versus biportal. So it is again the choice of the surgeon now. And see, if you give me, I can do both uniportal and biportal. But when you say minimal invasive or least invasive, definitely uniportal is less invasive than biportal technique. But definitely biportal has its own advantages. One is the cost. Second is the ease of doing and the speed of doing, because you are doing with a big instruments. And there you are using a bigger, what to say, rod length system. Because here, when you are using a 8 mm sheath, the rod length system will be 2 mm. Here you are using a bigger bigger lens of 4 mm. So the visualization is, the bigger the rod lens system, the more clarity is the field. A few advantages be, but again, person being a neurosurgeon, I am more of a uniportal person. So maybe in future we can marry both uniportal and biportal, come with more new innovations and new methods.
True. Actually, like my transformation had been because when we were doing intraventricular surgery, as we all know, we have to use uniportal system, and in that inline visualization systems do not help us to see what is going at the tip or across. But when we are doing an endonasal endoscopic pituitary surgery, then you have a completely whole different viewpoint. And that's actually this triangulation method of UBE has actually opened up a new gamut of area, and you can actually have a lot more expansile vision. So that the vision becomes much more better.
Yeah.
But then I really enjoyed your presentation and your talk. Thank you.
Thank you, Tapa. Thank you. Thank you.
Anybody else want to ask a question from the panel? Okay, Sam, you can ask.
Ask Professor a question. Professor, excellent examples of the cases. I think I've learned really a lot, and how endoscopic spine surgeries can be stretched for different indications. I'm interested to ask regarding the ulcerated disc, in which you say they have a lot of pain. Do you perform any diagnostic tests, like for example, a discogram, or a certain amount of time that you try conservative treatment first before you embark on surgery?
So these patients, first we try obviously the transforaminal epidural injections, which they do very well. So once the pain is gone or pain is improved, it means that it's more of pain coming from the epidural area because of the chronic inflammation leading to chemical mediators causing a lot of pain. So intradiscal, that is annulogram or the discogram. What happens is when you annulus, there is a chronic defect there. It is not a contained what is a tear. It is a tear which is open to the epidural space. If you do an annulogram, what is a discogram, it always leaks. It doesn't give a discogenic pain as we just see in a simple annular tear or a small tear. These patients, high intensity zone patients, they're chronic patients where the body is trying to heal that area. In that pursuit, there is a lot of neovascularization, forming it is as if a chronic ulcer like situation where it's a non-healing ulcer kind of a situation. As a result of which it is not healing, annulus is not getting sealed. So in such patients, doing a discogram will not help because they will never feel that pain. Discogram is helpful when it is contained. If in this patient you do a discogram, it leaks out. So even if you give saline or a steroid or a dye, it just leaks out. So there is no point in doing a discogram here, or a diagnostic or a provocative discogram is not useful here. All we do is we give either twice or thrice we give a chance of giving epidural transforaminal injections. If they fare better and they are coming with recurrent symptoms, then we offer them endoscopy, where we can go endoscopically, debride the entire vasculature and ablate all the nerve endings there, and they do very well. And it heals over a period of time. And you saw the MRI. This patient, after 4 years, the almost entire annulus is sealed, and he's a marathon runner, and he's again back to his routine marathon.
Okay, great. Thanks for the insights.
Okay, any more questions? I think we can come to an end because we have a long this in this field of lumbar surgery, from maximally invasive to minimally invasive to what we call now we have a pinhole like surgery with the least collateral damage, and it is something very best for the patient. And top of all, what I feel that all neurosurgeons should start doing the endoscopic spine surgery, because it is just like ENT surgeons who had a good dexterity of their hands when they do the skull base surgery. It is because they regularly do the functional endoscopic sinus surgery. Like that, if any neurosurgeon should take the lumbar disc or a cervical disc or a thoracic disc surgery as their first, because they will get enough experience with the endoscope. and when they go for a skull base or other region. So with this, I think we can wind up the session. Thank you, Dr. Sukumar Sara, for your excellent illuminating talk, and we will continue with our next session.
Thank you. Thank you. Thank you.
Thank you. Thank you. Thank you very much.
Yes, so we would like to invite Prof. Amitabha to continue on with his talk on the night.
Thank you, Dr. Sam. Is my screen visible?
Yes, it's beautiful. Yes, seen.
Okay, thank you. Actually, I was not supposed to give this talk, but then somehow because of some emergency situation, our speaker has to leave for her emergency work. So I decided to present on endoscopic intracranial hematoma evacuation because I realized that this technique is still not being adapted by most of these surgeons all over the world. And even though the outcome is far what I will be actually discussing in both literature as well as through my own experiences. Well, I have nothing significant or commercial related to this presentation. This whole talk is only on academic exchange. So depending upon our studies, what finding we have realized in Nepal per se is that even though only 15% of the acute stroke has been documented to be because of hemorrhages, in Nepal over the last 20 years in our studies, we have found that they have a significant rise in hemorrhagic component as compared to the ischemic stroke. And the median mortality rate in our place of the world is almost 40%, which is fairly high. And that's why this was very important for us to devise a method of proper management of these patients. And even those patients who survive, they have high morbidity and they pose a greater burden to the families. And this becomes very much pertinent, particularly in the developing countries like ours, where the breadwinner, if in case becomes ill, then the whole family becomes debt-ridden. Now, we all know that the mechanism of intracranial hemorrhage, how it causes brain injury, is just not related to the direct pressure of an acute expanding mass lesion because of the local compression of immediate surrounding brain tissue or widespread mechanical injury because of raised ICP, hydrocephalus, or herniation, but also because of secondary physiological and cellular pathways which are triggered by hematoma and its metabolized blood products, leading to cerebral edema, inflammation, and biochemical toxicity of hemoglobin, iron, and thrombin. What has also been shown that the early hematoma expansion by its mechanical shearing of surrounding vessels of its volume is a constant predictor of worse ICH outcome. And to add to this, to the problem, we do not have any major medical therapy for as an effective management. Besides some medical therapy to control the blood pressure for reversal of anticoagulation, which are aimed at limiting the hematoma expansion. Henceforth, we are actually left without any armamentarium, very effective armamentarium for controlling of this particular mechanism of ICH-related brain injury. If you see the current practice guideline, which has been published in 2022 by American Heart Association in the Journal of Stroke, which actually talks about the recommendation for use of craniotomy for supratentorial hemorrhages, the effect of craniotomy for supratentorial hemorrhage on mortality is still uncertain. And similarly, when we are talking about craniectomy for ICH, still the effect on its functional outcome is uncertain. So the both benefit of craniotomy and craniectomy is still uncertain on the effect of mortality. However, what this recommendation talks about is that minimal invasive approaches for evacuation of supratentorial ICH and intraventricular hemorrhage, as compared with the medical management alone, have demonstrated reduction in mortality. Now, this particular guideline actually creates a role of minimal invasive approaches, which has been supported by various randomized clinical trials and RCTs. And henceforth, misevacuation for intracranial hemorrhage has not only been shown to reduce mortality, but has also been shown to have a better functional outcome over the conventional craniotomy. And if in case it is associated with intraventricular hemorrhage, then neuroendoscopy together with IVD plus minor thrombolysis is now being prescribed by the various guidelines. Now, when we talk of endoscopic hematoma evacuation, the question may come up, why endoscopically? Well, it has a minimal invasive access to deep-seated hematoma. It can provide you a direct image or visual guidance. We can look on the side as well as the depth. And because of the continuous irrigation, the clot tends to disintegrate, dissolve, and flush, and the water actually flushes out the clot. And this procedure can also be done under local anesthesia if in case the patient is awake and cooperative. And besides, it relieves the hematoma volume and also reduces the perihematoma edema because of the persistent hematoma in the cavity. Now, this endoscopic hematoma evacuation has been attempted by two different ways, either by using a tube, which is also known as endoscopic assisted surgeries, or by a direct endoscopy where we use a water irrigation system, as we'll be talking in my presentation. So the benefit of direct endoscopic approaches has been that the water acts to wash the clot and also maintain hemostasis. The water creates a space for the work, and that's why it protects the brain from the suction. It protects the brain from cavity distortion and also protects the brain from excessive relaxation, which has been seen to cause subdural bleed, particularly when we are using a tube. Also, it provides a good vision for hemostasis. And from our practical classes in the lab, we must have realized that the water actually provides a good magnification for the vision. And this procedure, if in case, can be performed through a burr hole, and the local anesthesia can also be doable. It causes minimal trauma, and the benefit of endoscopic vision, as we'll be talking in my further slides, is very much better. And because of the water, there's no fogging of the scope, which is being seen in the dry media. So is it better than the stereotactic aspiration? Well, the study which has been published in Frontier Neurology has actually analyzed 258 patients. And what they found that the stereotactic aspiration group as well as suprancraniectomy group had a higher mortality as compared to the endoscopic evacuation group. And that's why they actually concluded that endoscopic evacuation significantly decreases the 6 months mortality in patients with hemorrhage with more than 40 ml as well as GCS of less than 8. Well, we do not have any direct comparison in terms of morbidity, but then if we see the meta-analysis, which uses the MISTI-3 patient group, it actually suggests that there is significant association between the extent of the clot removal and the mortality, if in case it is achieved properly. And also in the CLEAR-3 trial group, it has been shown that if in case we can achieve a near complete clot removal, these patients have far better functional benefit. If in case the near complete evacuation has been defined as more than 85% of the IVH volume. Now, our protocol in my center had been to use this procedure only for those deep-seated hematoma, which is more than 20 mils and has been associated with a rise in ICP or clinical duration. Deep-seated, by definition, should mean that the clot depth from the surface should be more than 1 centimeter and it is supratentorially located. Plus minus extension to the ventricles and plus minus associated with the hydrocephalus. Initially, we wanted to do this procedure only for those patients whose GCS is between 9 to 12, because less than 8, we used to go for decompressive connectomy associated to it. But now, after getting good results, we have actually expanded our indications to even GCS of 9. And we used to do this procedure within 72 hours of ictus. Better would be to do as soon as possible. So there are 4 core operative tenets which we always follow when we are doing a direct endoscopic evacuation of hematoma. The first and the foremost is minimal brain manipulation, and also to minimize the cavity distortion, and to obtain and maintain the hemostasis, and to have an intraoperative evaluation of completeness of evacuation, which I will be discussing in detail. So how we go to the hematoma is that we always make a target. The target is the center of the hematoma, and the entry area is the Cocker's point, which is 1 to 2 centimeter anterior to the coronal suture in the mid-pupillary line, or also can be defined by an 11 centimeter posterior from the clavella or 3 to 4 centimeter lateral from the midline. However, we always try to keep the trajectory along the longest axis of the hematoma so that the cavity distortion is minimum. So whenever we are going into it, if in case there are the hematoma is actually going into different cavities, then we can actually plan multiple trajectories, but that the entry area remains the same. So the navigation actually adds up to a value. We can actually plan it before we go into the patient, and also we can see how the instruments is going inside. So before we had the navigation system, we used ultrasound guided. For the ultrasound guided method, we had to make small craniotomy. But the benefit of ultrasound had been that it can help us to mark the center. It gauges the depth of the surface, and also the direction of the endoscope and the completeness of the procedure can be ascertained. So ultrasound was a very good method of doing this procedure. Now, when we use ultrasound, we use to make us a mini craniotomy in that cases. So because the foot area of the probe would not set into a small butthole. However, this procedure had helped us in many patients. Only thing is that we used to make a beveled margins at the edges so that the endoscope can go on other sides. So when we're using ultrasound guided, so this is the size of the craniotomy you can see in the post-op images. So this is how it looks like when with the endoscope is inside the hematoma. So thick clot on the surface, and then we can evacuate it with the suction. And then the patients did have a very good recovery, and usually used to leave an EVD catheter inside so that the residual cavity can also be sucked out. So we can have a good output, and the patients also can become much better much earlier. So how we are suctioning this clot? So we use the irrigation media of normal saline, which is kept at 15 centimeter height. So the 15 centimeter height has been kept so that from the tragus, so that the ICP does not goes out. We do not use any pressure pump. So just by the height of 15 centimeter, we allow the water to flow in. This also gives an idea that whenever the water stops flowing inside the cavity, we know that either our tube is inside the normal brain, or the pressure inside the brain is higher. So in that way, we always keep the channel of exiting saline open so that the ICP does not go up. And then we use a pressure regulator device like this. So we keep our suction attached to it, so we can actually release the negative suction, or we can increase it, but we try not to go it very high. And so whenever we come up to a clot, then we just insert the suction tube, that is the infant feeding tube, 10 French, into the particular clot, and then we suck it. And then again we change the endoscope, and then we see what we are doing. The whole idea is not to suck over the brain surface and to suck directly over the clot. So this is how we keep on doing it, and then we realize that after we remove a substantial amount of clot, the cavity starts opening up, and the whole area becomes less bloody, and then the whole vision becomes very clear. And then we can also identify the cavity. So this was our pilot study we did, and we finished it in 2020. We had an outcome variable of hematoma evacuation rate, operative time, intraoperative blood loss, Glasgow outcome scale at discharge, and 6 months after discharge in hospital stay. And we had a beautiful results from both pre and post-op analysis of various patients, where the patients did have a very significant hematoma evacuation and also very early recovery. And in this non-inferiority study, we did concluded that the endoscopic surgery had similar outcomes compared to that of microscopic hematoma evacuation in terms of operative time, intraoperative blood loss, Glasgow outcome scale at discharge, and at 6 months, together with the less tissue trauma, which is usually associated with the craniotomies. Well, the whole story is actually going around the endoscope. So the endoscope which we had been using is basically an Aspolab Invent. The beauty of this scope is that it has a wider channel for a working port, and then we have a 30-degree scope which can actually look on the side and much better. So, and this endoscope has helped us to evacuate in a lot of patients. And we usually use a pneumatic arm to fix the scope, because we do not do it pre-hand. And after the navigation has come into our materium, it has helped a lot, because it now had make the things much more faster. And then we can even do this procedure through a small burr hole, which just allows to fit our endoscope into. So this is how it looks like, the setup after the whole setup is attached with the navigation system and the pneumatic arm. So we go directly into the midpoint of the hematoma, and then we start sucking it with the suction tube under a graduated or a monitored suction. And as soon as we see the cavity, and whenever we enter the ventricle, we have to be wary about the choroid plexus. So whenever we see that, we stop our procedure, and then we just inspect the cavities and come out. And then usually we leave a drain inside so that anything which is there inside, particularly the water, should come out. And we can also measure the ICP through this tube in the post-operative period. For the last 2 periods, we have also been fortunate enough to have a cranial robot, a stealth auto guide system in our place. So we're using robotic guidance. The benefit of using a robotic guidance is that it is very fast. to reach to the hematoma, and the robotic movements actually make it very much precise. So this is how we are using the robot these days. After the patient's head is fixed, we can use the robot to come to a trajectory point, and then we can actually guide the whole procedure under visual as well as under the navigation guidance to evacuate the hematoma and to get the ICP control at the earliest. These days, we're also trying to do a local anesthetic procedure. This is done after the skull block is done. Skull block is given, and then we are fixing the skull again. And then on the navigation system, we are doing the procedure. We never attempt this procedure in a freehand system. We never do this procedure without fixing the head. The only problem is that whenever the scope is inside, the patient moves their head, then the whole thing is gone. The patient can be in trouble. So we do not allow it. And option number 2 is using EM navigation, but that again, this procedure has to be under GA so the patient is not moving by per se. So desirable but not widely available is the scuba technique using a poly device. This is a system which is very similar to a CUSA, which actually morcellates the clot and sucks through it. So this was published in 2018, and it's a very good device, but the only thing is the cost factor and the viability in our area. So till the time it is not available, I think this method of endoscopic guided hematoma suctioning or evacuation is much better. So the challenges had been that we do have a limitation of bimanual manipulation in the present endoscope. We have to make sure that the evacuation of the hematoma had been substantial, so that we should actually inspect the cavity before we come out. And then we should be very much aware of the fact that by our irrigation can increase the hematoma, the intracranial cranial pressure. So we should be very much aware of this fact. So we should be not allowing the water to stay inside the brain, and then try to see that the brain is not pulsating out through that small burr hole. And also the difficulty in removing large clots. So we try to irrigate it as much as possible. If in case in some cases of mine, they're the big clots, and particularly this is seen when we are operating on the day 3rd, the clot had become much more thicker, firmer. So in those cases, we have to do a mechanical lysis of the clot by using a grasper. But then this is done very selectively in those patients where we know that we are inside the clot and not over into the brain. Post-evacuation brain swelling had been our fear, but then we had not seen a single case in our series. We have been able to achieve a very good brain relaxation after the procedure, and this is very, very important to see once we are ending our surgery, to see that the brain has actually gone down. And then the brain swelling is not up. So if in case the brain swelling is up, then the patient should go for an immediate CT scan so that we can plan for a craniotomy or for the procedure accordingly. So post-operative reformation of blood clot can occur. So we have to be very much cognizant of the blood pressure monitoring. These patients do have bleeding or brain swelling, particularly the blood pressure is not controlled. In our scenario, the major cause is hypertensive bleed. So we have to control the blood pressure in all these patients meticulously. And then difficulty in hemostasis in some patients have been seen. And what we do in these cases is that we do a persistent endoscopic lavage. So that actually keeps on the hematoma or the bleeding in the control. If in case the bleeding is from an artery and cannot be controlled through an endoscopic lavage, then we go for endoscopic cautery or by using a radiofrequency plasma. Now, radiofrequency plasma, which the spine surgery uses, are much more bigger, so they cannot go through an endoscope. So what we have done in those cases is that we have actually used an ENT or laryngeal probe for that matter. These are very thin probes and can be easily navigated through the port. And as you can see in my video, in one of my case series, that we can actually use it to calculate the arterial beaters. And then, of course, we can do a mechanical compression by using a microcortinoid or by using a gel foam for these cases, if in case they do not complete. Now, there are certain knowledge gaps definitely in the literature. When we see of MIS approaches for ICH, there are various heterogeneous methods, and henceforth, the literature does not talk about what particular devices or things are used. Say, for example, in ICES study where they have used this Apollo devices, the devices, the same devices may not be used in other endoscopic procedures, so that the literature cannot compare apples to apples in that sense. Also, the current evidences does not support specific recommendations for which patients to be selected for surgery. And the optical time to surgical treatment for endoscopic approach also remains to be evaluated. And the functional outcome benefit is still debatable. Henceforth, we need to do a lot of research in this and a lot of documentations in this particular area. So to conclude, the recent guidelines do favor endoscopic approaches over conservative care. Endoscopic interventions compared with the craniotomy have far better functional outcomes. And endoscopic interventions does require surgeons and center skills and experience, and that's what it has to be trained, as Dr. Sukumar in the previous slide has been talking about, has spoken about how to develop your skills by going into various conferences and attending the workshops and then assisting some surgeons into various procedures. This particular step-by-step method of developing your skills helps a lot. As well as endoscopic hematoma evacuations are safe, and it provides an excellent way to evacuate spontaneous hematoma. Well, thank you for your patience listening, and I will be happy to take any questions. Thank you.
It's very interesting. I have done endoscopic ICH removals, but via the dry method, not using the endoscope directly. Mainly because I've tried that, and I guess the working channel is too small, and it takes forever to suck out the clot. So may I ask, in your scope, how do you actually suck out the clot in a timely manner? You presented that your working channel is bigger. Is that the secret to it? So maybe this is my first question. My next question would be the selection criteria for the patients. You say that GCS from 9 to 12, but I think a lot of times I have patients where the GCS is 14, 13, 14, with obvious weakness, with a clot size of maybe 25 cm cube. Would you consider doing endoscopic surgery for this type of patients? Yeah, thanks.
Well, thank you, Sam, for the question. Coming to the first question, so what we did was, this scope, like Ascolep Minop Invent, they have a wider bore. So they do allow a 10 French infant feeding tube to go inside it. So what we do is we hit the clot bank head on, and then we take the endoscope out and then push in this infant feeding tube to the length of the tube. We do not go into the center. We just remain inside the tube. And then we attach it to the negative suction and then suck the clot out in a rotatory fashion. So when we rotate the clot is sucked inside the tube and it is sucked out. And it also, the sheath actually starts morcellating, or rather it actually creates a clot dissection. And that's how we can take the clot safely out. And then as soon as we take the clot out, we again push in the endoscope, and the suction is ongoing, the irrigation is ongoing. So we can now look for another clot and then start sucking it that way. So this is how we do it sequentially. So it takes time, and we need to be patient. We cannot jump to remove every clot. So we have to do a very sequential manner. Now, coming to the second question of the criteria of the selection. So we take out the hematoma if only the hematoma size is more than 20 mils. And we try to keep the GCS criteria between 5 to 12 at the present moment of my practice. 14 GCS, I won't prescribe this surgery to every patient unless until we see that the patient is functionally much more severely debilitated. Say, for example, if the patient power is 1/5 or 0/5, we have in our past experiences found that the patient's power actually improves very fast if in case the hematoma is removed. So patients can be functionally mobilized much more earlier. But then we do not have a literature to support it. So we do discuss with our family members that, okay, we have an option with them, but then this is not scientifically proven. We do not have an evidences to show you on paper, but then this is something which we have found, and there are certain experiences which we had. So that is something which is an option given to the patients, but we do not suggest to every patient. Definitely.
Thank you. That means using a 10 French feeding tube and
Yeah.
indications if there's severe weakness, and then discussion with family for the second question. Okay, thank you so much. I think Prof. Nair wants to ask a question.
So it's a very excellent talk because it may not be innovative, but it is very useful technique because as I said earlier, this collateral damage when you do an open craniotomy is something which is devastating. So my question is, when you do, okay, because you have a selection criteria that is between 9 and less than 9. So all we put this endoscope in a brain which is tense, that is the ICP is raised. So after evacuation of hematoma, sometimes you may need a decompressive craniotomy. That means even after doing enough decompression, the brain may not be lax and the ICP is raised. That is my first question. Second question, when you are keeping the endoscope inside the brain and you remove the hematoma, if the pressure is high, the brain will fall into the brain, or the surrounding tissue will fall into the area of evacuation of the hematoma. So will it create a problem when you are doing this endoscopic removal of the hematoma? I think you understood my question.
Yeah, I got it. So thank you again for your questions. And in fact, these are very relevant questions, and these needs to be answered. And that's why our selection criteria was very strict to begin with. And I'm slowly expanding the criteria just after looking at my data and how my experience has gone through. I accept this is not an innovative technique. In fact, there's nothing to innovate now in medicine and surgery, right? Because most of our seniors have already done excellent work in the past, and we are trying to adapt many other procedures in our local scenario where these facilities or gadgets may not be available or too expensive to afford. Coming to your first questions regarding the swollen brain. So what we have found is that the patient GCS is less than 8, chances of brain edema is very, very high. So that's why when we started our procedure, we took the patients with GCS of more than 8, that is 9 to 12. In that cases, we found that the intracranial hematoma volume was the major factor for the patient's brain swelling. So the moment the hematoma was evacuated, the liquid stuff used to come out initially. So the ICP starts going down. And as I told in my presentation, when we are keeping the water irrigation at the height of 15 centimeter from the tragus, if the ICP is high, the water doesn't go inside the brain. So we are not doing any additional damage to the patient. That is one thing. And then I have, in my experience, found that once the hematoma is substantially removed, the brain starts relaxing down. Now, what water does it, that it actually avoids the distortion of the cavity. So when the cavities starts getting evacuated of the clot, the water is filling the space. And that's why it keeps the brain in its own position. So it does not allow the brain to fall. Now, this is the problem which I realized with the tube evacuation of the hematoma. When you're doing an air media, the cavity actually falls inside the wall. It starts actually collapsing inside the cavity, and that causes more injury, more bleeding, and then the whole thing starts distorting. And then sometime your clot may be hidden in one of the nooks and the corners, so those clots cannot be evacuated. So if you see my post-operative images, you could see that the major substantial hematoma was actually evacuated. The reason which I found was that the clots did not have the ability or the spaces to go and get hidden, because the water is expanding it, and that's why everything starts getting float and come to the suction which is being provided. So that's how the water actually plays a vital role. It not only washes but also dissects the clot, and also helps me to find out the small clots which are hiding somewhere. So we do not have to chase to the clot. We just have to morcellate and break the clot and then take it out, and then the whole clot starts coming out. I think I've answered your question. If in case if there's anything, please ask here.
Yes, you had a excellent way of making us understand what you are doing, and I understood what you said. But it's a very excellent technique. But one of my questions is, even after you are doing this evacuation, and you find that there is some increased pressure inside, that patient may need a decompressive craniotomy. how will you identify those subset patients? But as you said, if it is the GCS is 8, 9, that you mean you think that these patients will have an ICP not very high, so that evacuation hematoma will reduce the ICP. But in certain
That's
patient,
true.
even so, how will you know that a subset of patients, very few patients, if you have an excellent technique,
Yeah.
and I agree to your many of your points, because if you evacuate a hematoma, the recovery will be better. That is, even if it is anecdotal, from your experience, we are also experienced. A patient with a hematoma, plus minus case for evacuation. If you do evacuation, he will have a better post-operative course. So if it is it's very high after this, it's a subset of patient that have to be undergone decompressive craniotomy after endoscopy. Then do you have any your own techniques to identify what are those
Oh
subset
yes.
of patients?
So if in case I see that the hematoma volume is not substantial, say for example, it's not more than 30 mils or 40 mils, but still the patient GCS is very poor, and the patient has come up, say for example, 2 or 3 days after the hemorrhagic stroke, which is very usual in our scenario because patients are being referred from many places and they've come to our place maybe after 48 hours or 72 hours. Now, these patients are not good patients for endoscopic hematoma evacuations because by that time, the patient's edema has already generated and the hematoma may not be the only reason for the brain's raised ICP. So in these cases, we go straight for the decompressive cranectomy, take the hematoma using a microscope, so quick in and quick out. So rather than putting an endoscope and then wasting the time and then taking the patient for the second surgery or the decompressive cranectomy. Well, a small catch is that if in case we are doing an endoscopic hematoma evacuation and we see that the brain is still tense and it is not relaxing. So what we have done now is that we have a pediatric cardio probe, which have a very small footprint. And so we just put it inside our butthole and try to scan the brain intraoperatively itself. So if in case we see that there is still some hematoma, we try to track that hematoma. If there is no hematoma seen, then before we can we have two options. If the patient's conditions allow us to go for a CT scan, then we always go for a CT scan and take that decision definitively. If in case the patient condition does not allow, then on the table itself, we convert it into a craniotomy or a wide decompressive cranectomy, and that's how we salvage that procedure. But then in my series, we did not have that. This is just a hypothetical situation which I was just talking about. Because we always have to have a plan B and plan C ready if in case some certain eventualities come up.
Thank you, Professor, for your excellent tip information. Thank you.
Prof. Amitabh, may I ask, maybe slightly out of the context of your endoscopy evacuation, do you use urokinase or alteplase to dissolve the clot? Any experience in using this?
No, we have not used it in Nepal for two reasons. One is that it's very difficult to counsel the patients that I'm going to put a tube and then put a costly drug. These types of thrombolytic drugs comes at a price here, and patients usually do not consent. Looking at the price, so they go directly for the surgery rather than putting a tube and then waiting for 3-4 days for the clot to get lysed. And that's one of the experiences which we had. We did want to use it, but then somehow we did not find too much of acceptability in our patients.
Probably one question. Thanks, Professor Amit, for a very nice presentation. Wanted to ask regarding thalamic bleed. What would you do for the intraventricular portion of the? Will you put another endoscope and clear the hematoma, or just EVD? Thank you.
Oh yeah, so that's another good question. In fact, I did discuss about this in our presentation. So what I do in these cases is that I always make a trajectory which allows me to go inside the ventricle without taking the tube out. So what happens is whenever these clots are going into the intraventricular space, the clot itself has made a conduit into the ventricle. So whenever we push in the water irrigation actually makes that conduit much more bigger. So we do not have to push our endoscope through the brain tissue. Just after evacuating the hematoma and then trying to wash the cavity, we can actually go inside the ventricle directly. And there we remove the any intraventricular clots which is there, and then we just place the same inframphidian tube which we have been using to suck the things out. by punching more holes onto the side walls, we leave that particular catheter inside so that it can drain any remaining clots, and also the blood-stained CSF can come through without. And we also use the same tube as the ICP monitoring device in the post-operative.
Just an extension from the same question, say if the hydrocephalus is persistent and you need to change the tube, will you enter to the same point or you put the usual Kocher's point ventricular catheter? Thank you.
Oh, yeah. So usually if in case the patient does develop an hydrocephalus, then we do not use the same point. We use another point for one simple reason, because the tube had been there for a few days and that may get infected. So we do not try to touch the same place so as to avoid any chances of post-operative infections. So we make a new port.
Thank you very much, Professor.
Any other questions? If not, maybe you can end the session tonight. So we've been updated by Prof. Zubin that there are 500 over people who have joined us on WeChat, YouTube, and Zoom. So it has been a very fruitful session. So on behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to thank both the speakers today, Prof. Kumar Sura and Prof. Tapa, as well as Prof. Ajif Nair for the time and support for the ACNS webinar. Special thanks to Prof. Zubin for broadcasting this webinar on the WeChat channel. Special thanks to my co-host, Dr. Liu Bun Singh, for joining me today. So until we meet online next Saturday, it's bye-bye from all of us. Thank you very much for joining.